Good morning, everyone. First, I would like to say we hope here in corporate relations that you and your families all remain safe and well. I know it's been a challenging time for all of us. I'm Sherry Broder, a program director here at MIT Corporate Relations, which houses both our Industrial Liaison Program and MIT Startup Exchange. Our role is to connect our 250 plus corporate member companies to the MIT innovation ecosystem. Both the education, research, and innovation missions that are the academic engine of MIT and our incredibly dynamic startup community, which we connect to our corporate members through MIT Startup Exchange. We currently have over 1,900 startups as part of that community, so it's a pretty exciting part of our program. Working with industry is an essential part of our ecosystem. So really want to thank you for your time today and for all your support over all the years. Again, we couldn't do what we do without you, so really appreciate this. I'm really excited about today's session. I believe the faculty that we have with us today really exemplify the spirit of MIT. I think most faculty do, but these are just two of my favorites. I am a little prejudiced. They have quickly pivoted their research focus from to collaborating with students and colleagues to address the global challenge we all face. So, and they do this with passion, humor, and humility. Very characteristic of MIT faculty. So I'm really excited to have them here today. The format, we will spend 50 minutes with Dimitris Bertsimas and 50 minutes with Simon Johnson. We will be, and then 20 minutes, I've asked, they will both stay on at the end. They may have questions of each other, certainly entertain questions from the audience. So we want to make this very interactive. So let me stress that please ask questions early and often. We will pause during each presentation to take a couple of questions. And also please ask these questions in the Q&A session of your webinar. And also there's a feature where you can vote on questions. And I would greatly appreciate this as I'll be monitoring this. And I really want to ask the faculty members the questions that are most interest to you. So please ask questions again early and often in the Q&A section, and please vote on what you think are the most interesting questions. And with that, let's go to Dimitris. Enough for me. Dimitris is the Associate Dean for Business Analytics and a Professor of Operations Research at the MIT Sloan School. He started the very popular Master in Business Analytics program and has really been the force, along with his wife, Georgia, in the past several decades behind the incredibly successful MIT Operations Research Center. And I just have to mention that MIT is ranked #1 globally in operations research, and I'm very convinced Dimitris had a lot to do with that. He's mentored hundreds of students, started many companies, authored several books, and he's a wonderful collaborator, which I can personally attest to. I could go on, but I'd rather have you spend your time with Dimitris. He will talk today about his work on COVID analytics, and I think you'll find it all very fascinating. So with that, Dimitris.
Thank you, Sherry. Good morning, everybody, or good evening if you are in other parts of the world. So today I would like to talk about the work that I have done together with a large group of my students, mostly doctoral students and some of my colleagues, regarding COVID analytics, the use of analytics in trying to combat this pandemic that we are all facing. So if you would like to understand our work in more depth, I would like to point you to the website covidanalytics.io, which is updated daily with predictions about the disease around the world and whatever else we discover using our work. So, so what is the motivation? The motivation, of course, is with the growth of the global spread of the disease. My group and I have started working on this about mid-March and more or less non-stop. And we have developed methods to tackle the operational issues, clinical issues, epidemiological issues that arise from the disease. And during this process, we have partnered with many institutions of the order of about 40 hospitals around the world, governments, corporations, and so forth. And what I'm about to tell you is being utilized by governments, hospitals, companies, and various institutions. So you can take a look at the website. It has multiple aspects. I chose today to talk about two. The first is the so-called Delphi model. Differential equations lead to predictions for hospitalization and infections. It also makes some relation with my Greek origin. Let me tell you a little bit about that. So the first part, I will be talking about that. Then I will stop for questions. Then I will talk about our methods for making personalized predictions for infections and mortality based on clinical data. That will be my second part of the presentation. So, so the first task that we started, we actually publicized our first model beginning of April. The model is one of the few models that the CDC uses today for informing us about this disease. So typically, these prediction models are the first tools a policymaker uses to understand the severity of the epidemic, and also down the road guide decisions about what measures to take as we progress with the disease. This is to predict how the infections and hospitalizations, not exactly a trivial task. There are many difficulties, many challenges. First is data sparsity. So we have very little data known about the new virus from the start, and often incorrect assumptions are made, leading to potentially problematic projections. Second, there's of course human intervention that can affect the trajectory of the disease. Whether you do lockdowns earlier or later, whether you relax a policy and so forth. And we see some of these effects today as the disease has very different trajectories in different parts of the United States. And fundamentally also the disease has a significant parameter sensitivity in that this is a particularly non-robust system in which if a parameter in particular the key threshold, the threshold what's called R0, goes above a certain threshold, then the disease exponentiates, and then a lot of people will get infected, versus if it's below a certain level, then the disease dies. So understanding the role of these parameters is important. So the way we started this, so typically for people who know me, I believe in data. I believe less in models. Because I believe models exist in our imagination. They don't have an objective presence. So, but this is a complicated matter here because there is very little data to help us. So there are, in the 20th century, there has been 8 pandemics. I would say 3 or 4 very serious ones. This is definitely in this category, and few others less so. So, but there is very little data on that. So as a result, we chose to model the disease with a model rooted in epidemiology, the so-called compartmental model. The philosophy of this model is as follows. There is a population of susceptible people. These are not infected people indicated by a node S. This is epidemiology 101, what is being taught at universities. I will let you know soon how we modified these aspects. Then there is a set of exposed people that are infected but not yet contagious. Then out of this, some people become infected and contagious, and then some people recover. The generic epidemiological model is a system of, in this case, 4 states: susceptible, exposed, infected, and recovered. And it's a nonlinear system of differential equations. Nonlinear because we have terms like the product of susceptible and infected people that affect the rate of change for the exposed. This is a so-called SEIR model. The acronym is susceptible, exposed, infected, and recovered. And there are some parameters, as you can see, the parameter alpha, which is the infection rate, and so forth. So what we actually have done, this is sort of the inspiration. What we have actually done, we have built a model that, as the predecessor model suggests, we have a susceptible model, we have an exposed, infected, but then we started to become far more accurate, consistent with the data that we are having. So, for example, we have undetected people, both recovered and died. We have detected but hospitalized, also recovered and died, and detected and quarantined, recovered and died, and then R&D for recovered people and people who died. So this is a model, a compartmental model with 11 states. It's a system of 11 ordinary differential equations of the nonlinear kind, for which there are some parameters involved. So let's see what parameters and what does the model, what is the key innovations of the model relative to the state of the art. First of all, as you observed, we account for the underdetection. Underdetection is a problem that has been sizable controversy around it. The question is how many people are actually undetected, and our model explicitly accounts for lack of detection. Then we have separated, as you observed, recovery and deaths, because the rates associated with the states are very different. The rates of changing states from this state to another state is very different depending on whether you are recovered or died. Finally, a very important parameter that would play a very significant role is gamma of t. This is the rate of infection. The rate of infection, as you see from the equations, gamma of t is in red, is the rate of change of the infection. And we model it with a particular way to account for the various phases of government intervention. I will this in a minute. Just to illustrate the data that we used, we utilized daily data from New York Times that comes from the Johns Hopkins University database. That is, our models are all updated daily, data coming from there. For individuals, and in our website, we have predictions, daily predictions, up to September 15th at the moment for 120 countries and the 50 US states, about 170 units we predict. We are also having data for individual countries, sometimes because we are approached by governments or institutions to help them with specific information about countries. We have developed models for the states of Peru, for Russia, for South Africa, and many other countries, India, and so forth. So there are two types of parameters in the model. There are the parameters that have fixed and they are inferred. We have part of our effort has been in the beginning to collect data from about 200 papers that have been published and currently being published, but inform us about some parameters of the disease, like the time until recovery and hospitalization, which currently we assume it is 15 days, which is consistent with what people have reported, or the time for recovery of in an unhospitalized case was about 10 days and so forth. So there are some parameters that we fix and some parameters that are dependent on the particular geography. For example, the baseline infection rate, the time until death, the mortality rate. So this typically we estimate from data, for historical data, because we now have accumulated on a daily basis infections, deaths, and hospitalizations for all these places in the world that are reported. And from that, we fix parameters in such a way that our predictions and reality until that point are as close as possible. And then we use them moving forward. So there's a combination of parameters that we have fixed and have not changed, the ones on the right, and parameters that we update for a particular geography, and it's stated on the left. So I remember the gamma of t, the infection rate. The motivation for that is that initially, the initial response where the population awareness is still low the infection rate declines, but slowly. Then there's a sharp decline in the infection rate as policies to control the spread go into full force, lockdowns and the like. And then the society experiences this shock event and therefore adjusts its behavior. This is the second phase. And then the third phase is that there is a saturation of the policy effect represented by the diminishing marginal returns of the decline in the infection rate. So this particular infection, gamma of t, we model it with a particular mathematical function that has been particularly useful in making quite accurate predictions, as I will indicate in a minute. So regarding our projection results in summary, so as I mentioned, we make, in fact, 170, not 130 as the slide suggests, suggestions, predictions daily. And so far, I would say our results are strong. Our average accuracy is between 5 and 10% when we know what the accuracy is. To give you some examples of the accuracy. So on April 3rd, for example, we predicted 1.4 million cases in the US for May. We made this prediction April 3rd. It's in our website because we make daily predictions. We keep them. And in fact, it was 1.5 million, quite accurate, I would say. On April 17th, we made a prediction. At the time, Russia had 30,000 cases. We predicted 300,000 cases by May 20th, and it was at the time 318. Other examples include, we predicted in mid-May that Texas and California and Arizona will be at much higher rates of explosion than other states, and unfortunately, it became true in mid-June. So overall, I would say our predictions for deaths and infections is depending on the state and the country, the average is about roughly 5-6% for infections, about 9 to 10% for deaths. The death rate seems to be changing, as you perhaps have observed. In very recent months, mortality in the United States has declined relative to initial numbers. But for epidemics of this nature, I would say the prediction that we make so far has been reasonably accurate. And I would like also now to involve you in the participation. So people talk about, suppose there was, there's no doubt that the economy has suffered mightily from lockdowns that have been instituted in the United States. I would like to ask you, to pause for a minute, how many deaths would we have had in the United States if we did not have any lockdowns, and in the world? And the other question is, people say that the US government has been late or the states have been late in imposing lockdowns. So what would have happened if we imposed lockdowns 1 week earlier? At the moment in the US, we have about 120,000 deaths and growing. So I would like to, this has a bit of a shock factor, but that's what models can do. So the effect of lockdowns is as follows. There would be 3.1 million deaths in the US if we did not impose any lockdowns, as opposed to 120,000. And then 40 million deaths worldwide. The current number is about 500,000. So, at the same time, if we were to impose lockdowns 1 week earlier, then we would have just 1 week. So in most states, the lockdowns were imposed in mid-March, March 16th or so. If we did it 1 week earlier, let's say March 9th, the number of deaths in New York, which was the highest in the nation, still is, Louisiana and Massachusetts, each of them will experience with only one week earlier 80% less deaths. Just to illustrate, in New York in particular, we have 93% decline in deaths. So the vast majority, almost the totality of the deaths, would have been alleviated with 1 week earlier. So while I would say, I make these comments because while it is the case that the lockdowns have resulted in very significant economic destruction, people might say also human suffering and deaths might have been caused from this, although that's anecdotal, there's no evidence, quantitative evidence that I have seen. But it is fair to say that lockdowns have saved significant number of lives. When you don't do it carefully, as the United States seems to be doing in some parts of it, the numbers, unfortunately, are growing, and unfortunately, significantly. And I also prepared a poll. So, Katrina, I was wondering if you can circulate the poll for the audience. I don't know how I interact with it, but you see it in front of you. So, which countries will be among the two highest incidence rate per 100,000 people in September 15th? And you have the choices: England, unfortunately it's a mistake, Great Britain, but Brazil, Peru, USA, Russia, and South Africa. So among these countries, which are the two that would be the highest? So please fill it. Now, why is this question even relevant? Why do we care about it? As you know, there are significant efforts in the United States and globally to create vaccines. It's our best effort for combating the disease. Moderna is starting clinical trials in July, AstraZeneca in August, Pfizer and Johnson & Johnson in September. So by September, where all four companies will be in full force, understanding where the majority of the epidemic will be, so that we have enough people to have, is relevant. So, so I see that the answer is Brazil and the United States. And I would say this is what models can do. Unfortunately, these questions, the answers are wrong. In Brazil and the United States, these are the two highest countries today. But in the period in September, our predictions is Peru and South Africa. Notice that this is per people, not the total number. So that's an indication what models can help you. It could basically guide you to basically counter the intuition, what's happening that is bad today, that it will also happen in the future. I hope I made myself clear on that. So I would also like now to comment on the other aspect of our work of understanding the effect of government interventions. Given the effect of lockdowns, of course, states and governments have decreased, have relaxed the lockdowns at various degrees. So what I would like now to understand is the effect of relaxing the policy from a complete lockdown, staying at home, to no measures, and then there are intermediates like restrict mass gatherings, and do not allow businesses, mass gatherings, and schools, and so forth. Out of these 6 policies, applying them, what would be the effect? That's particularly relevant of what is happening in the western part of the United States today, where from what it said, what it seems is that the states have opened somewhat prematurely. So what we have done is that we have utilized past data. We know for every state on every day what is the declared policy. So we measured the effect that we have observed in the data in terms of infections for the various measures. So no measure is sort of the baseline, and so 87% for restrict mass gatherings. It says that we increase the level of infection by 13%, 100 minus 87. So just to illustrate mathematically how we model that, this is the gamma of t business that I talked to you about. It's a particular formula that we use, arctangent of at a particular time. So let's say at a particular time, a current policy changes. That's the current state. And at that point, the way we find it is that we measure the effect. So this is proportional to the numbers I showed you before. And after that, the arctangent continues. In other words, if we go from lockdown to no measures, then the effect will increase by 76.76 instead of 1. If we go, for example, from mass gatherings to school only lockdown, and schools to lockdown, it will actually go down the infection rate by 24.24. So these numbers have been estimated by a vast. We have 170 units in our predictions, for which we have daily declaration of state. Most of them, of course, stay constant, but we can measure the effect. If we do that, you observe that, as an example, in New York, and you can go to the website and experiment with different states and different countries, is that we would expect that the difference from no measure and lockdowns in New York, while non-negligible, is not as substantial. In other words, in September, we expect that the number of deaths, which currently is of the order of 30,000 in New York, will go, maybe staying roughly constant, maybe 31,000 under lockdowns, to 40,000 until September. But if you go to states like California and Arizona and so forth, or Texas, you will see a very different story, where relaxing the policies makes a very substantial difference that unfortunately I think might be happening at the moment. So this would be a point to pause for a minute. I'm now in the midpoint of the presentation, in which I have covered some of the basics of the Delphi model, and I would like to open it for questions. Sari, perhaps you can help me?
I'm seeing a trend in questions. One that I think is critical is, have you taken into effects, or do you see any seasonal effects? Yeah, because there was a lot of talk that it would go away in the summer, and clearly with the heat, it has not done that. So
this is not the case. It's not going away. What we have seen, at least in the United States, but not in Europe, is that the death rate in this period is lower than what, let's say, New York experienced in the middle of the pandemic in April. The death rate has declined, but we have not seen. But this is not, for example, true in Europe. So this might be various reasons for that. One might be, and I don't have a great definitive answer, but it might be that this might be related with the load, the virus load. People that have only incidental contact might have less viral contact than otherwise. The temperature might actually also decrease the spread of the virus and so forth, but definitely has not eliminated it. So the hope we had that the summer would affect it in a very significant way has not materialized.
Okay. There's also, thank you. There's a lot of questions around demographics. In terms of, I guess personally, my question is around age. Yeah. As I think there's possibly a lot of undetected cases in younger people that are spreading because they don't have the effects. There's questions about race, because there's certainly been a much larger percentage of underrepresented minorities that are getting that. That could be situational, which I think most people expect, or could be other reasons, but
yeah, I can tell you what I know.
On those two.
Yeah, race and age. Yeah, so we currently have developed a more detailed model. We have 12 risk classes by age and gender. So we have one risk class below the age of 40. Younger people seem to have become sick much less, and definitely the death rate is significantly less by age. And then the risk increases very significantly above 80, for example. The risk for death is upwards of 20%, whereas for very young people is below 1%, or significantly less than that even. So definitely there is race, there is age and gender matters. On the race matter, people anecdotally report on that, and I've seen the data to suggest that that's the case, but we don't yet include race in our calculations because we don't have appropriate data yet on that. As I will indicate in the second part of the presentation, you will see that in terms of mortality, age is the most important factor. Other things are important, but age is the most important. And being male also is a risk factor. I mean, female patients fare better with respect to mortality. At the moment, while there's discussion, we don't fully understand the reason for the significant increase of incidence and mortality for African American populations. And I don't have particular insights of, is it socioeconomic, is it biological? I do not know. But the data does suggest that there is let's call it bias, unfortunate negative bias towards African American people.
Absolutely. Well, I'll take one more quick one. And then a lot of these questions for the audience, we will ask it either at the end if there's time before 11:50. If not, we will pose them to both Dimitri and Simon in the last 20 minutes. But anyway, there's a question that's got a number of likes on the use of masks. I mean, have you considered that as opposed to, it seems like you focused on lockdowns.
Yes.
Have you seen any influence from the use of masks, or any comments on that quickly?
Our models do not include it, primarily because we don't know the population that wears and does not wear masks. And there is strong evidence to support that the use of masks helps significantly, but we have not included it in the model, which is, I would say, one of the things to improve. But having data, what part of the population wears and does not wear masks, is not an easy task.
Excellent. Well, let's continue on with the presentation. It's
okay.
On time here.
There will be another chance.
We have tons of questions.
So the second part of my story is understanding and personalizing the estimation for COVID-19 patients. So this is particularly relevant for European countries in the middle of the pandemic, and I hope it will not be relevant again when the healthcare system might be overcome. What is happening at the moment in the southern western part of the United States is reminiscent of this issue. The issue is as follows. So let's say somebody comes to the hospital, and you would like to understand how likely it is that, or somebody doesn't even come to the hospital, calls from home and says, I have some symptoms. Should I come to have a test or not? In the presence, of course, if we have ample testing, the answer would be an obvious yes. But in many parts of the world, including the United States, unfortunately, we don't have a gigantic number of tests available. So can we then utilize data to assess the probability of infection without tests? Second, what happens if you have lab tests, namely blood tests, that of course are available and much more quickly available? Can you say something there? And then for hospitals, it's also an interesting question. What is the probability of mortality so they can prioritize the resources? So we have developed models using a large collection of hospitals, about 40 of them. We started with the majority of our data comes from Europe, but we also have data from the United States. But we have data from about 40 hospitals, the majority of which are in Europe, and have maybe 3 hospitals in the US. We also have some hospitals in South America. And we have publicized our personalized calculators in the website. You can utilize them and see for yourself. But the idea is as follows. And this is a different mode of analysis. The previous mode of analysis very much depended on a mathematical model, an epidemiological model, a set of differential equations. This one very much depends on data and data alone, and then uses machine learning methods to learn from that for making more accurate predictions. So let me give you an example of this. Let's talk about mortality first. So as I mentioned, the utility of the tool is to support patient triage and resource prioritization in a capacity-constrained system. Particularly relevant, as you know, one of the reasons Italy and Spain had very significant number of deaths relative to the population is, at least in part, because the healthcare system was overcome. Of course, the fear was that this might have happened in the United States. We started building in New York. I remind you, there was we built a temporary hospital with capacity of 3,000 people. We brought a Navy ship to help and so forth. But overall, it appeared that the US so far has managed that aspect of the disease. So triaging and priority is life and death decisions, and I think this tool could be helpful in making more objective decisions about these matters. So so this is what I'm about to present in this presentation is an earlier version where we have data only from Cremona, Italy, which is in the middle of Lombardia, and about roughly 1,500, 3,000 patients, half from Spain and half from Italy. That population had a very high degree of mortality, 25%. And it utilized features like demographics, comorbidities, vital readings, lab values, and so forth. Just to illustrate the results. So, and this is back to your question, Sari, regarding age and so forth. So our overall calculator in terms of accuracy, we utilize a method that's called boosted trees, which is a somewhat black box method. And this tries to decipher what the key indicators are. But you see that age is the most important factor. The higher the age, as you see, it's the red means the probability of mortality increases. The higher the age, the more risky the patient is. And the accuracy is very high. I would say 96% area under the curve is a very strong model when we have lab values. And when you don't have lab values, it's still a very high 92%. So then BUN is an indicator of infection of the kidneys, how well your kidneys work. And you see again, the higher BUN values, the higher the mortality. You see other indicators, oxygen saturation. The higher the oxygen saturation, the lower the saturation, the higher the probability of mortality, and so forth. And this is the case that you have lab values. If you don't have lab values, then age, again, and oxygen saturation, temperature, being the gender is important. Being male, for example, as I mentioned, increases the probability of mortality and the heart rate. So, so this particular calculator is, especially without lab values, is currently in use in several organizations that would like to, that are in contemplating whether to allow their employees to come to work and have a test there as a pre-triaging methodology with some good responses. So the prediction, so for prediction whether you have infection or not mortality is also useful as a cost-effective, non-invasive way of filtering patients who need to be tested. So this could be used for people that are at home, so they can actually do this analysis. You only need, you have to know, of course, your age, your gender, and then you know your temperature, your blood pressure, your heart rate, and whether you have some comorbidities. And then the algorithm tells you whether you are in a high risk, medium risk, or high risk population. So overall, we have found that there is usefulness of this for these tests. We have calibrated in a variety of settings with strong results. We are currently working to incorporate, in addition to these demographics and clinical characteristics, to also incorporate modes of transportation. Who do you live with? How many people do you want to live? The ages of the people, and so forth, and also where you have been from a contact tracing perspective. That could be useful as we reopen. Let's take MIT in the future. We hope that, expect, and MIT will be open in the fall term. Having some understanding of these characteristics might guide us where to prioritize testing. This is not, its aim is not to replace testing. Its aim is to guide how to give priority in an environment that testing is limited. As I mentioned, the infection calculator is not as strong as the mortality calculator, but it's quite strong. With lab values is 92%, and without lab values is 83%. And just to demonstrate, oxygen saturation is a very important factor: temperature, age, respiratory frequency, and heart rate. And these are people that are easily measurable, even automatically by wearables. Oxygen saturation is not wide. I mean, people have a thermometer at home. They can understand the temperature. They can measure the respiratory frequency by measuring breaths over a minute and the heart rate. Oxygen saturation is not as widely available, but we also in our website have a possibility of somebody saying just to utilize whether you have shortness of breath or not. If you have labs, then it's a more complicated story, but a more accurate one. So sizably more accurate. So let me give you a bit of a demonstration on this. So I hope you can see it. So let's say this is for mortality. Suppose you have no lab values. Let's say you are a male, let's say age 70. Let's say your temperature is 102, high temperature. Your heart rate is, let's say, 80. Your oxygen saturation, let's say you don't have data. Do you have shortness of breath? And let's say yes. And let's say in terms of comorbidities, let's say you have diabetes. And then you submit. And it says the score of mortality is 28%. Of course, a scary thought. But on the other hand, it's a diabetic patient who is on the older side, male. It has many risk factors that are not to your favor. You have shortness of breath, and you have a disease. Of course, if you allow, let's say, if you go to infections, so you have values similar. Let's say male, age 70, say 75, temperature, let's say 100, heart rate 85. Respiratory frequency, let's say 18, normal. And let's say, do you have shortness of breath? Yes. What's the probability that you have so it's very high. The probability that you have the infection, you are in the first quartile of probabilities. And the reason is you have shortness of breath, you are older, you have higher temperature, your respiratory frequency and heart rate are normal. So this to give you a sense of how to use these calculators. So some of the clinical insights we have found is that the key risk factors for mortality, as I mentioned, are age, BUN, CRP is the overall condition, and oxygen saturation and AST. These are sort of characteristics of overall health. The literature has validated in a descriptive way, ours was predictive way, but it's inconsistent with what the literature is talking about. In terms of risk factors for infection, if you have labs, you see CRP, white blood counts, calcium, AST, and so forth, and temperature. So what we have found, in other words, from the data in a predictive way using machine learning is consistent with what in isolation risk factors that the literature has reported. But we put them together in a calculator that gives you a concrete estimate of the risk you face. So in conclusion, what I have presented today is a model that enhanced model for the compartment model, the Delphi model, that it allows nonlinear modeling to and understand the policies, the effective policies. It has been quite accurate so far. And at the moment, we are working on trying to model the second wave that we expect will happen in the fall of 2020. A complicated matter because there have not been recorded efforts, prior efforts on how to do that. So we have been modeling. We're about to release our findings in the next few weeks. As you saw in this example, the key was a model. This was the key primitive. Data played a supporting role. In the second, in the clinical risk calculator, data played the primitive role. Machine learning was a tool to help it. And we have found, and I believe these models could be helpful, and in fact, they're already helpful. Many hospitals in Europe are utilizing it for prioritizing patients for resources in the hospital, and even before coming to the hospital, whether or not to invite people to have testing. And on this note, I would like to open it for questions again. I have left 5 minutes for that. Sari, perhaps you can help.
I'm coming back and we have questions filing in, so I'm asking the audience to vote, so I don't have to swim through all the questions that are coming in, but I saw a couple that I think are most interesting. I think I may save for question with Simon, because I think they'd be interesting to hear both your take on it. But I think one question that comes up is this whole question of herd immunity.
Yep.
And in a place like, I guess, Arizona, I wasn't aware that Arizona has done nothing, but in a place like that, do your models predict like how long it would take to get herd immunity, or whether this is a strategy?
My view is that herd immunity is not a strategy. I told you that that is a strategy, all right, but it will have very deadly consequences. I would say without therapeutics and vaccines, to open the society completely, which unfortunately seems to be happening in some places, is a significant mistake. It would lead to very significant deaths, because we have really, even though there are some therapeutics, I'm not saying we have zero, but there's chloroquine, remdesivir. There are drugs, but limited. So I would say I'm not a big supporter of herd immunity, because by that time, the consequences of the population, you need for 60, 70%, would be very severe.
Yeah, interesting question is about the mutation of the virus. I mean, the death rate appears to be going down.
Yes. In the US, not in Europe. In Europe, it's not going down. In the US, it's going down, but not in Europe. Yes.
So is there? Do you believe it's mutating? And what I mean, is your model thinking of?
The model does not take into account mutations. It only indirectly, because it adjusts to data, so it doesn't have exact modeling. It is the case that the virus in the US has mutated from the virus that came from Europe. The virus in China, where the disease originated, has different mutations than the past. So there's no doubt that virus mutate. This is definitely true for the flu and the common flu and so forth. That's why it is very difficult to cope for it. And that's why I believe that even you have a successful vaccine, it would not lead to total cure, because there's in fact there is the mutation effect. But at the moment, the epidemiological model we have doesn't directly model it. It only indirectly models it, because it finds parameters that match the data. So in effect, adjust the parameters to match what is happening. So if there is a mutation, indirectly it affects the parameters, and therefore indirectly affects the prediction. But we don't have an explicit modeling of mutation.
Okay. And I think we have time at least for one more. I think this one, and I'll probably ask this again with both you and Simon, but it is around the second wave. There's a lot of talk about this. You gave us a prediction for what countries will be seeing it most. What are you thinking in terms of a second wave, and what the risk is?
Yeah, the second wave is a difficult modeling task. We are currently, as I mentioned, working on it. We have limited data from a second wave that has happened in the 20th century 4 times. One in a very significant way. Most of the deaths from the Spanish flu happened in the second wave. There are other instances, not as deadly, but there are. So we have built a model that has 2 parameters, namely what is the probability distribution of when the second wave will start, and what is the intensity of it. Of course, we don't know it exactly, so we just have a distribution, and then we do simulations to understand what is the effect over time. So our model would have some predictions. Of course, I make these predictions with some humility, because I have to admit, even though I know that our models have been successful so far, but the second wave is a new arena for which there's not a lot of evidence to go by. So, but that's the best we can, and I think more data, more intelligence is better than none. So, and that's what I'm doing. But there's no doubt this is a complex matter. I also don't know whether Moderna is starting clinical trials in July. So the degree to which, or there are new therapeutics, there are other effects that it's unknowable whether we can.
But you can adjust your model fairly easily as these.
Adjust the model easily if we know it, but at the moment we don't know much.
Okay.
So, yeah.
And the correlation, as a last comment, the correlation between the real world and your current model is very good, correct?
Very high. It's
very high.
5 to 10%.
Excellent.